Welcome to Clinical Lab Chat, part of the MedCore Podcast Network. I'm Chris Wolski, Director of Business Intelligence for CLP, and today we'll be talking about a partnership that's aiming to improve women's health. Joining me once again for a return visit to Clinical Lab Chat is Dr. Jeff Andrews, a board-certified gynecologist and Vice President of Global Medical Affairs for Diagnostic Solutions at BD. Jeff, welcome back to Clinical Lab Chat. It's great to have you back. And last time you were here, you had just spoken at the UN, and we talked about the recent approval of patient sample collection for HPV and cervical cancer. Now, since that time, BD and MD Anderson have partnered on a program designed to put this approval into practice, which I think is a very exciting for both patients and labs. So let's get into it. How exactly are BD and MD Anderson working together on this program?
Well, thanks, Chris, and it's great to be back. So there's a set of federally qualified health centers under the heading of Sioux Clinica in the most southern part of Texas that MD Anderson has a long-standing relationship with, supporting the initiatives there for healthcare. So when the opportunity for self-collection for cervical cancer screening came up, MD Anderson proposed to Sioux Clinica that they work on this together, and those two chose BD on Clarity to be the HPV assay for the work that they're doing. Of course, the assay is already approved in the U.S., so this is an on-label use. The nature of the research is what we call an implementation study, to go through the different things about communicating to patients, having them participate, how the sample is processed and the results communicated back, and how the follow-up is, and to try to package up any lessons learned to share with other federally qualified health centers and any healthcare facility that wants to initiate a similar program.
Okay. And just so I'm clear, is there a particular patient demographic that you're aiming to reach? I mean, I think you said it's southern Texas, so that's probably it's a very diverse area. Is that a specific target demographic you're looking at?
Yeah, thanks for asking. So, there are people within the U.S. who are well screened. There's been a lot of vaccination, so that's great. But there's a significant proportion of women in the U.S. who are underscreened and never screened. Mm-hmm. It's about 25% of the total population, about 60% of cancers. Disproportionately affecting Black women, Hispanic women, and women living in rural or poor conditions. So if we think about the incidence of cervical cancer in the U.S., overall it's 6 per 100,000 women. We're trying to get to a WHO goal of 4 per 100,000 women. Okay. But in Texas, it's 9.6 per 100,000, which is 60% higher. And in this particular county, Cameron County, it's 10.7 per 100,000, so 80% higher. Texas ranks last in the country for healthcare coverage, unfortunately. And overall, 22% of women in the age group that we target for cervical cancer screening, 15 to 44, they have no healthcare coverage in Texas versus 10 to 12% nationally. So you're right, this particular county, Cameron County, and a little bit of the adjoining Wolski County, it's 89% Latina, and importantly, 25% of the population have no insurance of any kind. So that's obviously one of the barriers to receiving health care. Yeah. So the other thing that's exciting, Chris, I mentioned WHO. They have a goal they call 90-70-90. So globally, they want, so far 196 countries have signed on, 90% eligible vaccinated, 70% eligible screened, and 90% of precancers treated. Sue Clinica said, we're going to do 90-90-90. So they're looking to step up from, instead of 70% screened, they're trying to reach 90%. And they're also doing the vaccination, which is very important. So there's a lot of energy there. It's a very exciting place for this to roll out. And of course, MD Anderson is internationally recognized, so that's a powerful partner.
Yeah, very powerful. So, we've talked about the benefits of HPV sample self-collection in the past, I think in the last episode, but that you were on. But let's back up a bit. You kind of touched on this just a minute ago. What are some of the challenges that women generally face with HPV and cervical cancer screening? And now they have MD Anderson has a very aggressive goal that you just outlined. How are they hoping to overcome this? You have people who aren't being screened, primarily probably in many cases because they don't have health care coverage. So how do we break those barriers? What are those challenges and how do we break through them? How do we get to that 90-90-90?
Right. So there's awareness, interestingly, is one of the main barriers. So for women who are not aware that it's important to be screened, who should be screened, how often to be screened, getting the word out is important. A new program like this is obviously an opportunity to do that. It happens to be about self-sampling, but even if women hear this message and choose traditional sampling, that's fine. It's just a matter of raising awareness. Then of the women who are aware but they're not participating, there's often factors to do with personal trauma or pain, discomfort with the healthcare system, and then you're right, ability to pay. Now, in the U.S., ability to pay should not be a barrier to cervical cancer screening. I think we spoke on the previous podcast. Every state and every county has a fund to support breast and cervical cancer screening. But again, most people are not aware, and they feel that if they don't have health insurance, they don't have health care, they don't have access to health care. Now, I mentioned this is a federally qualified health center. They don't turn anybody away, and they have a sliding scale. So if somebody doesn't have insurance, they're able to adjust the charge, if you will. So it's not free care, but it's heavily subsidized care, and there are other alternatives as well. So I think getting the word out, encouraging people, word of mouth will be very important. Hey, I tried this, and it was super easy, and I got the result, and I feel good about it. I think that's gonna help as well.
Okay. And as you know, we talked about this last time, I think, and regular listeners know, testing access is something I talk about all the time, probably ad nauseum for some people. But how is this program and BD's on Clarity assay specifically aiding testing access? So it's good, it's great to have a goal, but you have to have the means to do this. So how do you, just talked about some of the federally subsidized opportunities for paying for the test, but how does the on Clarity assay specifically aid in that access and in the self-sampling part of it?
Right. So coverage is in the U.S. is related to FDA approvals. So the fact that we have FDA approval for both traditional conventional use and also self-collection is important. Trying to share information about where women can access care in a county or a federally qualified health center is important. There's less time involved doing a self-collection than waiting your turn, going in a room, undressing, going through all that stuff. So that's less of a commitment. Our ultimate goal in the U.S. is to have another option, which is at-home self-collection. That's even less time off work, less transportation issue, less childcare issue. So that's where we're heading in the U.S. is this combination of choice where you could do your self-collection at home, do it at a healthcare facility, or have a traditional physical exam by a clinician and a collection by the clinician.
Right. And I think we talked about this last time about self-collection, most of us have had, urine tests and things at a regular checkup. But there's always sample integrity. How does the unclarity help with sample integrity? I'm always worried about messing up a urine test on my checkups. I haven't, thankfully. But how have we ensure that we have sample integrity? Because the worst thing is you take a sample and then you have to go back and do it again because you messed it up. So is this a pretty bulletproof test, or is there some extra steps that have to be taken, I guess?
Well, Chris, the worst thing you could have done with your urine sample is not screwed the lid on tight. But
I always do that.
Yeah. Now, most of us listening have swabbed our noses for
right.
COVID testing.
Sure.
Typically, if we were doing that, either we or the facility we were at took that swab and immediately put it in a media and did the testing. But in this case, what we're currently doing in the healthcare facility, the swab is sterile inside a sheath. The patient removes the swab, does the sample, and replaces it inside the sheath, and it kind of snaps into place. And then they hand that off. So that's a dry swab that gets labeled by the healthcare facility and sent to the lab like any other sample.
Okay.
And so the other thing is there's an internal control for a human gene. So we will know if the sample came from a human and if it's adequate. In other words, so if there was some kind of mix-up and it was just an unused swab, the internal control would say this is not a proper sample, so there's that protection. I mentioned the at-home. The idea there is that the patient would place the swab into an empty molecular tube and cap the tube. There's no liquid there, so hopefully they'll get the cap on correctly. But when that tube arrives in the lab, it just goes onto our instrument and it's processed from there. So, and of course there's labeling with barcodes and things that track that sample to the order.
Right. So it sounds like it's very, on the patient side of it, it sounds like it's very much like what we're used to between, a urine test and swabbing for COVID, et cetera. So a lot of things we've gotten used to over the last few years, and not so different than we would expect. Okay.
And in the women's healthcare space, self-swabbing for sexually transmitted infection, self-swabbing for vaginitis has been in place for many years. All of the tests in the U.S. have that as a claim, including ours. So I think women and women's healthcare providers are accustomed to this, and I don't think it could be any simpler, Chris. And of course,
that's great.
Yeah, there's pictures and words. And in this case, in English and in Spanish for this implementation study.
Sure. Okay. I just I'm always because we certainly, and you pointed this out, you're dealing with a population who may have some challenges with childcare or transportation, etc. And you certainly want a test that's fairly bulletproof and something that would be useful for both the healthcare providers and the labs themselves. So, what kind of we're talking about underserved communities here. What kind of spotlight is this program shining on testing access for HPV and cervical cancer screening, particularly for women in this underserved area? If you have good insurance, I go to my doctor, I have insurance, and there's a whole menu that comes up for the tests I need. Same with my wife when she goes in. We're fortunate that we have insurance and a regular healthcare professional. What is this shining on those underserved communities? And we talked about that a little bit, but is this starting a discussion at all in MD Anderson and in that community? How's BD thinking about this in terms of helping underserved communities and yourself as a physician, and someone who's spoken at the UN and seeing this big global perspective in terms of underserved communities getting this kind of care? Because unfortunately, the numbers are underserved communities or people without insurance the majority in many places. So how does something like On Clarity and a program like MD Anderson help with this access, or just shining the need for this kind of testing in order to meet these goals?
Yeah, so some people use the phrase coal face. So the miners who are actually standing in front of the coal face are the closest to the thing. So I think the people who are closest to this challenge in women's health care are already highly motivated to go the last mile and reach everybody. And the further people are away from it and the less they know about it, the more we need information. And I would say groups like the actual clinic, like MD Anderson, are already there and going above and beyond. Every country that I visit that's looking at this challenge to eliminate cervical cancer needs as one element political will. You need the government to be involved and to put funding support and to participate in some of the positive communication. So in the U.S., that's both the state and federal government. But I think you're right, shining a spotlight helps a lot. I mean, we're doing it right now. There was a launch which got a bit of press splash, both in that county and in general. I just got back yesterday from Indonesia, and they're aware of this there because MD Anderson is actively helping in Indonesia. So folks in Indonesia know about this little study going on in a county in Texas. So yeah, I think as we go forward in time, there'll be positive results coming out of this, and others will take the point, if they can do it, we can do it. I think that's part of the message. This needs to spread across the U.S. There's no reason that we can't achieve the WHO goal. And to flip that around, it would be embarrassing if we didn't and other low and middle income countries got there ahead of us.
Yeah, for sure. And, so we've been talking a lot about patients, we've been talking about MD Anderson. How is self-sampling technology helping laboratories in particular? Most of our audience are laboratorians, and so how does this help with them processing tests or getting tests and helping physicians, diagnose and treat women?
Well, if we go back to my earlier statement that 25% of eligible women in the U.S. are unscreened or underscreened, we are trying to reach those women. We think that self-collection is an important tool for reaching those women, so that's going to increase the overall screening.
Right.
And when the overall screening increases, that business is going through labs for testing.
Right.
Yeah, so very important.
Great. And so we've talked a lot about self-sampling in many different ways, but what do you see as the long-term benefits of self-sampling? Is that going to get us to those numbers quicker, or and make cervical cancer, not necessarily eliminate it, but make it at least far less common than it was? And we talked a little bit about the vaccines, of course, are helping significantly, but they only can go so far as well. So what are these long-term benefits? We're talking about right now, but what are these long-term benefits?
So I think when self-collection came up, it was both a reachable technical solution, but also something that was very appealing to women, that they would want to do this. And then if we think about countries where there simply aren't enough providers that can do the classic pelvic exam with a speculum, or even the physical space to do it, you can imagine a health fair pop up on a Sunday somewhere where you could self-collect from hundreds of people, but there's no way that you and I could examine them all. So that's one of the biggest benefits. Then we can keep going and say, well, offering choice is very important in healthcare right now, and this is certainly an additional choice. Like, you don't have to do it this way, but this is an option. So I think that's an important aspect. Again, if we go outside the United States, particularly to a country where the government is responsible for the cancer screening program, they are looking for wise use of their resources. And self-collection represents a tremendous savings in both human resources and physical space. So that's a big benefit. In the U.S., we don't tend to pay as much attention to cost effectiveness, but the same is true in the U.S. Another aspect in the U.S. is that many primary care providers don't do clinician collection pap tests. They refer the patient just for that reason to an obstetrician gynecologist. So now a primary care doctor could order self-collection and look after that patient. I really don't think it's a great use of a specialist's time to do a pap test. It's one of the first things you learn in medical school, much less OBGYN residency. So we could apply our resources better. And I think both the patient and the primary care doctor would appreciate being able to add that as just something else they do. Like you mentioned, there's a list of things that you do when it's time for your checkup. So that's just pop in the bathroom, give us a urine sample and a vaginal collection, and we'll send this off to the lab.
Yep. And you go on, and if everything's A-okay, you're set for another year or however long before you need to come back.
So, Chris, in this case, it's even better. Yeah, it's 3 to 5 years. If your HPV is negative,
oh wow,
you don't have to do that again for 3 to 5 years. So it's no longer annual testing.
Yeah. So there you go. So again, that resource use, and we talk about this all the time, and I think we've talked about this in the past as well. That with various workforce shortages. I mean, we talk about laboratorian shortages. There is I think there is an OBGYN shortage. There's primary care shortages. There's shortages all over the place with various generalists and specialists. So even in the U.S., this is certainly a good use of our resources. So, well, excellent. So unfortunately, though, yet again, we've come to the end of our time. Jeff, thanks as always for joining me, and this is really cool, exciting stuff, and I think it's a bit of good news that we can take into the coming year. I also want to thank you, the laboratory audience, for listening. Look for more episodes of Clinical Lab Chat in the near future, and visit us online at clpmag.com and on all the major social media platforms. And until next time, be well.